Karuppiah, left main bifurcation PCI. I see him there. Yeah. So,
thanks for the opportunity. Dear colleagues, I would like to discuss this topic, left main bifurcation PCI, with a case presentation. It's a 59-year-old gentleman. He presented to the outpatient with class 2 angina. History of posterior inferior MI few days ago, not list. Risk factors being long-term diabetes and hypertension, and the echocardiogram showed mild LV dysfunction with ejection fraction of 45%. That's the diagnostic picture. As you could see, there is a bifurcation lesion in the left main before the origin of the LAD and the circumflex, which is in different views. It also confirms involvement of the ostium of the LAD and circumflex. RCA showed subtotal obstruction, possible culprit lesion for the current presentation. The patient could not decide about the revascularization option at that stage. They wanted time, but the next morning, the patient was kept in the CCU. Next morning, he developed severe pulmonary edema and ventricular tachycardia. He was reverted with DC shock and intubated. Echocardiogram at that stage showed severe LV dysfunction with ejection fraction of 20% and hypotension, blood pressure of 80/60. Obviously, he needed emergency revascularization. They didn't want bypass surgery. They wanted to go ahead with a percutaneous intervention. Because of his hypotension, poor LV function, I first put him on in IABP and then took the diagnostic shot again with the guide catheter. Guide catheter confirmed the lesion with the persistence of TIMI3 flow both in the LAD and circumflex. So I wanted to decide the percutaneous intervention strategy for this left main distal bifurcation. I am more familiar and fluent with the Cullott technique. As you are aware, Cullott technique gives a nice coverage of the ostium of the side branch. Not only that, the carina is very less with the Cullott. Because I am used to this technique of two-stent strategy, even in emergency, I thought I will go with the Cullott technique. So I predilate initially I wanted a quick reperfusion to the LAD territory. I predilated the lesion with the 2.5 balloon, and that is the post predilatation. This is the post predilatation of the both LAD and circumflex. I had some difficulty in passing the balloon through the left main to circumflex. So I thought there might be some calcium. So I did the IVAS. IVAS confirmed I could not pass the IVAS beyond the origin of the circumflex. But the IVAS confirmed at least moderate calcification in the circumflex. It looked like some deep calcium. So I wanted to prepare the lesion well before considering implanting the stent. I prepared the lesion between the circumflex and left main with a cutting balloon of 3x10 size, and then after preparing the lesion with the cutting balloon, I prepared it with the NC balloon of the same size, and then started implanting the 3x330 1-inch stent, which was no problem in implanting the stent. And then the next step was obviously to optimize the left main part of the stent with the pot. I did the pot with 4x6. That is the IVAS calculation. I think it was 4.5x6. After the pot, that is the pot, first pot. After the pot, obviously the pot, as you are aware, not only optimizes the optimization and opposition of the stent to the left main, also it makes the access to the LAD very easy. But you need to be careful to pass the LAD wire in the distal stent. For that, I jailed the initial LAD wire, and which helps in confirming whether the stent is distal or not. Obviously, you could see the distance between the jailed wire and the currently passed wire, which probably confirms it is in the distal stent. With that, I did the first kissing. How does this first kissing help? This was not a usual step in the conventional Cullott. This was the recently added step in the Cullott technique. The first step kissing helps in optimizing the result of the LAD here. Very well. The long-term outcomes are good. Supposed to be the recent evidence suggests the long-term outcomes, the side branch, in this case, LAD is very good if you do the first kissing. So after the first kissing, I implanted the stent in the LAD. Possible. After implanting the LAD stent, you do the part again. That's important. Another important step. This is the second part after implanting the LAD stent over the circumflex to left main stent. After doing this part, you optimize the distal LAD stent and then prepare the bed for the second kissing. That's the final kissing with the same size of the balloons. The final kissing was done. It went on very well. The procedure was tolerated very well by the patient. The final kissing obviously helps in optimizing the carina position and also optimizing the distal part of the left main stent. Then after the final kissing, you go for the final part, which is very important to do the final part. Then the final part should be in the proximal part of the stent only. The distal balloon should not go to the carina. If it goes to the carina, you undo everything. So you need to be very careful. The final part is done in the proximal part of the stent. That is the final result. I thought I got a very good angiographic results with this technique, even if it is an emergency revascularization procedure, and the patient did very well. Next day, the blood pressure improved. I removed the IABP within 24 hours. Blood pressure became 140/80. EF improved to 35% and discharged the patient on the 5th day. Take home message: double kissing culotte technique introduces additional kissing balloon inflation after implantation of the first stent. First kissing balloon produces desired result in the LAD in this case and prepares the access and makes access to the LAD after main branch stenting more predictable. Recent evidence to suggest MACE and TLR rate less compared to the conventional culotte. Thank you very much. Open for discussion.
Absolutely, Dr. Karuppiah, well described DK crush, and you showed the steps, except for the couple of steps possibly you did not show for the sake of time. But this is known as DK culotte. Modification of the conventional culotte into 3 pots and 2 kissings, the way we do the DK crush, and therefore people call this as double kissing culotte, as you said, or DK culotte. The only point I would say is that whenever you show those kissings, try to emphasize on sequential kiss. High pressure side branch first, high pressure main branch second, and then a moderate pressure kissing balloon. So sequential kissing, so that you get the stent struts right up to the ostium, and chances of the ostial restenosis are less, both in the first as well as in the second kiss. And then, of course, since you had IVUS, you could have used for the final assessment of, most important, not only the areas, distal and proximal and everything, but a strut-free or a link-free carina. The figure of 8 of carina, so that you show that there is no link or strut between the two. So the most important point. And one more thing I appreciated is the use of IVUS rather than OCT in an emergency situation, where every dye you push in will raise the LVDP a bit more. So one has to be very, very choosy or careful when you do in such emergency situation. But nicely, I would say this was a chip case, left main PCI chip case. In an emergency, you did this ACS situation. Fortunately, the EGFR was good, I believe, in your case, right?
Yeah.
So
it was around 1.6.
Yeah, and post-operative recovery was also good, as you described, and I hope the follow-up is also good for this patient.
Yeah, I did this maybe 3 weeks ago, sir.
Yeah. Okay. Yeah.
The short-term follow-up was good.
Short-term follow-up is good. Yeah, because that is also one important thing when you do in ACS, you don't want any stent thrombosis in the short term. And especially as we all know that when you use IVUS, there are mortality benefits.